Hello and welcome to Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I am your host, Shawn Needham, along with my producer, Lindsay, and we are streaming live from the Moses Lake Professional Pharmacy Studio today. And today at our midweek podcast, which is normally on Thursday, we have it on Wednesday today. And why is that? That is because tomorrow is Thanksgiving, and just a reminder of be thankful. Be thankful for so many things. I can tell you what I'm thankful for. I'm thankful for this podcast. I have so much fun doing this podcast and educating and empowering our listeners and viewers on all kinds of things healthcare. And I thank you for listening and thank you for watching. So, with that being said, we stream live every day, every week, usually on Mondays, 1 to 2 p.m. Pacific Standard Time, and our midweek podcast on Thursday, 8 to 9 a.m. You can find us on my personal Facebook page, so Shawn Needham's personal Facebook page, and the Moses Lake Professional Pharmacy YouTube site. Also, all the podcast forums in a couple days. This will be downloaded to those forums, and you can listen to it there. So iTunes, Google, SoundCloud, and so on. iHeartRadio we just added not too long ago. So go to those podcasts, your favorite podcast sites, and subscribe. Don't want to miss an episode. And please go to our YouTube site, Moses Lake Professional Pharmacy YouTube. Hit subscribe there so you don't miss any episodes. There we are on episode 100 right now, I think. This is episode 100. So today we have Dr. Daniel Paull. He is an orthopedic surgeon, and he has a little bit different of practice model. You guys that follow our podcast have known that we've had doctors all over the country, mostly primary care doctors that are cash-only doctors. And it's called DPC, or direct primary care, and they have a monthly membership fee. And always one of the issues that they've always had with this cash revolution of healthcare, and remember, I've been talking about cash, the free market in healthcare, and a cash revolution where, the government or an insurance company does not control your health. I've been talking about that for ever on this podcast, since the inception of this podcast. And why do I talk about that? Well, part of the reason is I wrote a book on it. I wrote a book on it called Sickened: How the Government Ruined Healthcare and How to Fix It. And of course, there's a 6-step solution in there. And really, in general, the solution is free market principles. That's what's going to save healthcare. The government is not going to save it. The government ruined it. They're not going to save it. Free market solutions. And that means you are in control. And that means the doctor that you choose are in control. So it's important on who you choose. Now, one of the free market solutions with direct primary care was kind of first, which makes a lot of sense because primary care kind of has to be first. And then they need a place to refer people if it's something out of their scope. And one of the barriers has been that it was more difficult to refer to specialists who specialize in free market solutions and in cash solutions. So we've had a urologist on here. We are going to have a cash rheumatologist here next week, I believe. And today we have Daniel Paull. He's an orthopedic surgeon, and he is a cash orthopedic surgeon down in Colorado. And with that, I'm going to let him introduce himself and give a little bit of his history and what his practice does now. Dr. Paull, welcome to our show.
Well, Shawn, thanks for having me. I appreciate it. It always helps kind of get the word out about new ways of doing things. Otherwise, people think that the only way of doing things is the way we've always done them.
Right.
So a little bit about my practice. I guess to know about my practice, you kind of have to know about the origins of it, or why I'm doing what I'm doing. So I broke a lot of bones when I was 14. I had skied into a tree. I thankfully survived. And since then, I came from a family of engineers. I'm like, hey, this is pretty awesome. They kind of fixed me up. I'm back running around and stuff again. This is what I want to do, right? So I made that decision. I want to be an orthopedic surgeon probably at about 14 or 15.
Wow.
And most of us that go into medicine, yeah, and I don't think that's uncommon. I think I may have been on the older side. I mean, I think people know from like they're really young, or they kind of have something happen like me, or it's like they don't know what to do and their whole family's doctors, and they're like, well, I guess I'll just be a doctor. I mean, I've seen that too. But
So
anyways, so,
yeah, go ahead.
you make this decision when you're 14 or 15, and, you don't really think about it too much. And most people that end up going, I mean, I used to think I was the most stubborn person I knew besides one friend I had. And then I went to medical school, and I was not the most stubborn person I knew anymore. And that other friend I had, he also went to medical school. Um, but
Well, and
uh, but anyways, so
and
getting
especially when you got into your residency with surgery, you realized you weren't the most stubborn person, right?
oh my goodness, no, not at all. I mean, that's like a requirement.
Right, right.
That
That's kind
is
of a
like a
joke,
real
but kind of
requirement.
serious.
Yeah, I
Anyway,
mean,
so
it has its pluses and minuses. But
yeah.
yeah, so so you get into medical school, do medical school, get an orthopedic surgery residency, which is more competitive, and I do that. And like, look, I never thought I'd be doing this practice. So I start a hand surgery fellowship. I liked hand surgery, and then a couple of things happened. One was I had well, I'll put it this way. One was I was searching for a job at that time, right? That's the track that you're going on. And I interviewed like at this place, and it's like these guys are all miserable, and they're just telling me how much money they made in the early '90s and how bitter they are. And I'm like, okay, this is the kind of vibe I'm getting. And then as I was looking for a job out in Colorado, because that's where my wife's from, and I've dragged her all over the country at this point, Florida, Ohio, New York. I've dragged her all over the place. It's like I can't find a job, or the ones I find are like, it's a competitive market. So it's you take call for our entire practice every day, or here's your 4-month guarantee, and then figure it out on your own.
Right.
And for those that don't know, the standard's 2 years, and it's very tough to build a full practice in 4 months. So that was going on. I was super unhappy. I kind of had like a family crisis at the same time, which created and I had this. It all culminated in this existential crisis of like, what am I doing? Like, what am I doing? You keep going through med school residency. It's like, oh, light at the end of the tunnel, and then there's just another tunnel. And I think that was kind of this realization that like I'm just going through these series of tunnels, and like, what am I doing? Like, am I going to be doing this forever? And so I didn't know what to do. I knew I could quit. So, quit my fellowship, broke lease, moved out here to Colorado. And I had one friend from medical school in South Florida, and he started a house call practice, like doing internal medicine type stuff. And not only was he happier than anybody I knew, he was doing better financially than anybody I knew. And I'm like, all right, there's something here. And, I was just kind of in this state of desperation and existential crisis. And I said, let's just go for it. I'm going to roll the dice, and, we'll see what happens. So that was kind of the origins of it.
Well, and if you don't mind talking a little bit more about doctors being unhappy, I write about it in my book actually that there's a huge burnout rate for doctors, and I think people on the outside that don't know, they just think that doctors go into medical school, they start making good money as doctors, they just love what they do, and I will tell you, most the doctors that I know aren't really happy with what they do, especially when they're working inside some big inside the system, so to speak. Now, doctors like yourself and a lot of the direct primary care doctors that we work with in our pharmacy and we've interviewed in this podcast, they love what they're doing. But talk a little bit about depression and suicide from doctors that are burnt out. You mentioned that before in some of our communications.
Yeah. So, you take a group of people who are very resilient and, or before they start medical school are the same or better than their peers as far as kind of mental health. And you kind of put them in an impossible situation where, you're expected to see as many people as you humanly can, while your clinical manager or some CMO that hasn't practiced medicine in 15 years tells you to do that. And you're compressing these visits down to a really short period of time. Now, I believe that you cannot compress these visits down to that short of time without losing quality. And I think that's what doctors are finding. I may know what's going on with somebody really fast, but that doesn't mean they do. And part of the taking care of a person is, in what I'm contrasting that to, instead of comparing that, taking care of body parts. Taking care of a person, you need to get to know them and know what they want to do and come up with a treatment plan together and have good communication. And and part of that's education as well. You know, how many times does someone go to the doctor and like, oh, what did the doctor say? I don't know, something with my arm. What do you need to do? I don't know, surgery or something. It's next week. You know, it's unbelievable, but that's all the system cares about. There's no compensation for education or that aspect of it, and they just want you to see as many people as humanly possible. So now you got a situation where you're running through people, not developing a relationship, which is why you went in it, and you know you're delivering substandard care, because how can you not be? You know, if you give me 3 times, triple the amount of, if I'm seeing someone in 7 minutes, it's going to be short. If I get 45 minutes or as long as I want, they're going to feel like I'm going to do a much better job, and they're going to think so too. So you have a situation where doctors have essentially lost all the control of their practice, but yet they keep all the responsibility. Nobody wants to touch that. No hospital administrator is going to go, you know what, I'll take the blame for all these things you do. No, they leave that alone. So it's this pressure cooker, and you do not get any system improvement either. The only system improvement you get is reimbursement related, and it's usually for the worst. So, the insurance companies are incentivized not to pay. And that's just true. They can say whatever they want. That's the truth. So what they'll do is they add a lot of hoops to jump through. And as time goes on, there's more hoops that get added, and you need to hire more hoop jumpers. And all of a sudden you have this crazy EMR and things you need to do. Look, doctors don't hate technology. If you look at us, we all have iPhones or smartphones. We're not Luddites. We don't like EMRs because they're billing. They're meant for billing. They're not meant for note taking. So you're turning the doctor into a biller. And that's where all these click boxes are. That's why the medical assistant goes in the room before. And that's not to really add any value most of the time. I mean, that's just filling out click boxes and taking your vitals and stuff that, may not matter all the time. Like for orthopedics, we don't do anything with that information. It's just for billing. So it's this whole billing machine, and they get stuck in it. So, so anyways, the only system changes you get are from reimbursement related. If insurance companies came out and tomorrow said, we're not going to pay you unless you rate all of your notes while standing on your left leg only, the next day there'd be somebody in the clinic saying, you need to stand on your left leg while writing these notes and document it. Okay. And like that change comes immediately. But any change you try to get for actually bettering care, it's very impossible. It's very difficult in that system. I got in trouble a lot as an intern. That's not for like medical reasons. It's because I see system issues that I thought were terrible. And I'd say, hey, this is pretty bad. And they say the same thing. This is the way we've always done it. And, and it's not just that, they really beat it into you. So, you come out saying, oh man, I just don't want to make any waves. Let me just keep my head down. And they take advantage of that. And I've been successful by making waves and kind of going back to my baseline here. But anyways, to answer your question, to go back, doctors it's an impossible situation. It's a situation in they're getting run ragged, and the system's telling, hey, you're not resilient enough. Like it's a you problem, but it's not. It's a system problem. These are some of the most resilient people around. Working 24 plus hour shifts for years on end can delay gratification for a decade. You're talking resilient people, and then the system, they're running them ragged, and then they're getting burnt out and saying, hey, it's your fault, you're burning out. And then unfortunately, a lot of them don't, they get depressed. I've had before, in myself, and that's part of my existential crisis. But you feel like there's no way out, and it just gets worse and worse. And then unfortunately, all these doctors, they end up committing suicide. It's the highest suicide rate of any profession right now.
Wow.
And then everyone's questioning why. Well, we know why. But they treat you as a commodity, these systems. They just want you to produce, like you're a widget, like people come in and you produce medical care. And, you'll even have that in practices where they'll be like, oh, this is our most productive doctor. That's not saying it's their best doctor. It's their most productive doctor. And that's all they care about. And, if you're booking surgery after surgery and filling up the schedule, they love you. Does that mean those surgeries are necessary? I know. I've heard stories of, prominent surgeons where, the CMO will go to them and say, hey, why aren't you doing more surgeries? Why don't you do surgery on this guy? Well, it's not indicated. Well, you need to expand your indications. And if you don't believe me, I'll tell you this story, which is kind of probably one of the craziest stories I know in this kind of topic. It was a family med doctor who was working out in Kansas, I think somewhere in Kansas, and she was doing deliveries. And I don't know where she was specifically. But anyways, she had a nurse anesthetist with her so she could do C-sections. And that guy was supposed to be on call, I guess, 24 hours. But I guess on his own, he decided he wasn't going to do that. So when she would get someone that was high-risk pregnancy or C-section, she would kind of send them down, the road to, to the hospital system. And I think, the CMO or CEO came up to her and said, why are you sending all these, we're not making money on the delivery. Why are you sending all these, pregnant mothers away? And she says, hey, this guy's not coming into work and I can't do these C-sections safely. To which he said, well, you should inject lidocaine and cut the baby out.
Wow. Seriously.
Yeah, that's out there.
Wow.
These people are in charge of the culture of these systems. So, she quit, which was good. But I mean, those are the types of people. You get people that are so business minded and lose touch with all humanity, and you get things like that.
That's really scary. And I'm really not that surprised because that's kind of where medicine has come to. And unfortunately, Dr. Paull, there's a lot of doctors that don't stand up to that stuff. I mean, fortunately, you found a solution. A lot of other doctors do too, and they just leave the system. Because I think in a lot of ways, the system is so broken, I don't think you can fix it. I think the way to fix the system is to get out of the system. So, which is exactly what you did. And sometimes the doctors that get out of the system, they quit practicing medicine. And that's sad because there's a lot of doctors, a lot of good doctors that have probably left medicine because of that. So tell us what your solution is. Your solution was you wanted to still practice medicine, but on your own terms. And that's Easy Orthopedics. So tell us a little bit about Easy Orthopedics.
Yeah, sure. So, I mean, when I started, I knew that I can't take insurance. I can't do it. I can hire 5 people just to collect. And then all of a sudden you're trying to run a high volume based practice. And look, I'm never going to do it as good as those guys. And I don't want to. So right away, if you want to get out of the system, you cannot take insurance. You just cannot be associated with it. So right away, that'll drop your overhead tremendously. Now, the next thing I did was I started up, and I'd still do mostly house calls. So then I don't even have an office. And here's what a lot of docs don't really realize is that all the regulations that we have, they're reimbursement related. They're not legal regulations.
Right.
You legally need a medical license, and obviously you want to practice in the standard of care, and some states require malpractice, which is here, and I have it, of course. But all this other junk, meaningful use, all that's junk. It's all reimbursement related. Once you remove yourself from these reimbursement systems, that stuff is gone. You can practice like you want to practice. And that's really nice. But yeah, so instead of focusing on, well, how do I get as many patients as I can? Let me buy the most expensive surgical machine and market that. I'm looking at the other side of it. Well, how do I decrease my overhead as low as I can? So A, not taking insurance. B, doing house calls. And actually what I found is that since, I'd see people, other docs around town, and they say, hey, well, could you see this patient at my office? I'm like, sure. Now, all of a sudden, I have like 4 or 5 offices I go to. And if they're like, hey, if you need to see someone on your own here, just go ahead. So like I kind of have office space that I'm not really paying for it because when I'm there, it's value added.
Absolutely.
And, I carry everything around to do casting, splinting, injections, suturing, kind of basic stuff that you would do in an ER. Obviously, surgical stuff that needs to be done in a surgery center. So that decreased overhead a lot. And then there's also little other things. If there's an inexpensive way to do something that's good, I'm going to find it. So like electronic medical records. Even some DPC docs will say, well, yeah, I pay $300 a month for this, which is better than the $2,000 I paid before. If you're paying $24,000 a year for your EMR, something is seriously wrong.
Rip off.
So what I found is what do you really need for that? You need you need something that's HIPAA compliant and basically can store notes for you. So what I use is through Google, it's called G Suite, and you pay for that. And you can sign a business agreement to make it HIPAA compliant. So I have a HIPAA compliant Google Drive with unlimited storage, and that's $12 a month per user. So I have 2 users. It's me and my wife, right? That's the only people in the business. For a while, it was just me. So that's $24 a month. And it's great. You can template all your notes out. You can do whatever you want. It's super efficient. And it has the whole email capability that comes with Gmail. So there's just, I think in the medical field, things are expensive just when you attach the word medical to it. It's almost like a wedding stuff, like you could get catering for a wedding and catering for an event, same food. The wedding is double, so if you can kind of get out of that sphere, you can end up kind of being all right. I'm not going to these expensive, EMRs and, you're paying for the billing. That's what you're paying for with these EMRs. They're saying, hey, you can write your crappy notes in our system, and with no subject, no text, just all click boxes, and we'll translate that into bill that insurance will pay, and we'll stay up to date on all these codes, which, by the way, you have to pay for because the AMA owns all those codes. Some people may not know that. The codes are owned by the American Medical Association and have been. So your EMR, and I think the doctors itself are paying licensing fees to use these codes. So
it's crazy. We've actually, through this podcast, one of the great things about this podcast is I've learned a lot by talking to doctors like yourself, and I learned that the AMA, they own the CPT codes, and that's where a majority of their money comes from. So if people think that the AMA wants to fix our medical billing problems, our medical system, absolutely not. They are so deep involved. It's probably the only thing that's keeping them in business, because I think only 15% of doctors are members of the AMA now. So most doctors don't take the AMA that seriously. The AMA is making money off, basically being an accessory to the crime in the system. And CPT codes, as you were kind of alluding to, the only reason for a CPT code, or an ICD-9 code for that matter, is really for billing. That's the only reason. It has nothing to do with taking care of the patient necessarily.
yeah, no, that's definitely true with the CPT codes. And actually, the ICD-9 codes are international. And I think ICD-10 maybe, you'll have to look into this. I think it came out in the 90s, and it was just a classification of diseases for epidemiological purposes. And then we kind of co-opted it into our billing system. That's why you'll see strange codes like, someone get bitten by a cow or something, because everyone in the system is like, why the hell would they have a code for that? And it's like, well, some epidemiologist wants to know how many people get bit by cows. So I don't know.
Yeah.
All these sort of strange things. But yeah, I agree. It is kind of part of the dumpster fire that is our healthcare system at the moment.
So tell us a little bit about Easy Orthopedics. So let's say patient breaks his leg. I know that's a very, very general term. Let's say he breaks his leg. It's a non-compound fracture. How would you deal with that? Could you deal with that in your office?
Well, I think the first thing is they contact us and we talk, and look, if their femur is broken in half or they have a broken hip, I'm going to tell them to go to the ER, right? Like that's something need to get taken care of. But if it's not something like that, then we tell them the transparent price. They pay it. You get my bag, and I'm off, and I go see them. Take care of what they need to, and then I give them my personal number. Because when someone wants to contact the doctor now in the system, what do? You call the office front desk. You probably wait a minute, get transferred to the medical assistant if you're lucky, who will ask the doctor, and then the doctor tells the medical assistant to gets back to you, and that usually doesn't happen right away. So, it's a terrible system, and the doctor's got to answer the question anyway. So I give them my personal number. They can call or text with any questions. If it's something simple like casting steroid injection, I can do it there. Otherwise, if it's surgery, then you're kind of talking about, what is this a necessary surgery? What happens if I do it? What happens if I don't do it? And if they want to go proceed with it, and it's cash-based elective surgery, set up, at a surgery center at an assigned time and date. But it's pretty simple. There's not, and they pay me time of service. That's why I call it Easy Orthopedics. It's really not that complicated. They just call me and I come out and see them. Or if they don't want to, I can see them at the office. Or if they need an X-ray or an MRI, I'll see them at one of the offices I go to, which is also an imaging center, which has cash-based pricing too.
Awesome.
So, For instance, I saw this girl who had a skiing accident recently, and it looked like she may have torn her ACL. She didn't, thankfully. But I was able to see her same day, get the MRI ordered next day, and then tell her shortly afterwards, hey, it's not your ACL, but you do have a non-displaced fracture that doesn't require surgery. And this and the other thing, and I think the total cost of that will be probably less than $1,000. I mean, you could pay more for the MRI alone if you have insurance.
So MRI and everything, and your consultation fee and everything was less than $1,000 for that visit. Is that correct?
Yeah, and most of that's probably the MRI cost, and that's me going to her house. And you're talking same day visit, next day MRI. And if this was insurance, she would have had to pay more. If she had a high deductible, she would pay more for just the MRI, and it would take weeks. And then I would have to do an hour-long prior authorization to get it approved.
Yep.
So, it's just so much easier, and it's so much better. I mean, a lot of people still think like, well, I need to have insurance, but it's not what it used to be. It wasn't 2 decades ago where they just kind of covered everything and everything was all right. I mean, you have a high deductible, the network's paper thin, the billing shenanigans have gotten crazy, and like you're just going to end up, financially worse off, and health-wise worse off too, because your care is going to be, the doc's not going to spend as long as with you. The care is going to be worse, and it's going to be a lot more expensive, I think.
Yeah, I mean, I
think things, right? If you have something catastrophic.
Correct. I think for catastrophic stuff, we need some kind of, insurance. That's what it was meant for in the first place. But for your routine stuff, even like you're talking about broken legs and things like that, I just don't think it's worth it. Because like you say, you're better off paying cash. I mean, the insurance system is ripping people off. And that is one of the goals of this podcast, to realize, to educate and empower people that their health insurance, there's no such thing as good health insurance. There's not. I mean, honestly, the best you can hope for is you don't have some kind of catastrophic thing that the health insurance has to cover. But there is no such thing as good insurance anymore. There's just not. Because the routine stuff, you're better off paying cash. Finding a doctor like yourself, an imaging center like you talk about, and pay cash, because you'll save a lot more money and a lot more time. And how much is time worth?
Right. I mean, it would be the equivalent if you had car insurance for your, like, it'd be the equivalent if car insurance covered every aspect of your car. It would basically be like, well, we'll pay for a new pair of tires only after you've bought a pair of tires. And we'll pay for an oil change only after you've gotten 3 oil changes in a 6-month period. And it's $100 a month. But next month, it's going to go up to $120 for no reason whatsoever. I mean,
right.
When people think of cash, right, and I think this is something that I've learned, it's really not so much cash, it's just not insurance, right? I don't have the capacity to deal with insurance. So, and cash comes in different forms, right? So some of it is what I just described, me going cash pay patient, call me up, I go see them. Some of it also, I work on medical liens as well. So I found out that if someone's involved in a car accident, I'm actually a pretty decent fit for them, because most of their injuries are musculoskeletal. And I'll hold a medical lien for 1.5 years or so, and then get paid when the case settles. So to me, yes, I have to wait a long time, and if the case doesn't settle, then I won't get paid, but I don't have to deal with the insurance shenanigans.
Right.
So that's also cash. Or if I'm trying to get into the employer side of business as well, I could, you talk about musculoskeletal cost containment. I mean, I think that could be huge business, and that's cash also. So you need to be creative in finding ways to just not take insurance, but it's not just strictly, here, let me see you. Okay, you pay me. I mean, that's part of it, but I think I've learned that there's more avenues, than just that. Or you're talking about, medical legal stuff and record reviews and things like that. At least for an orthopedic surgeon, that's a source of cash as well, or independent medical exams. I mean, these are all just different avenues that you supplement your practice with.
Absolutely. So we were talking a little bit before the show about hospitals denying admitting privileges to physicians. And I think back when I used to be on a hospital board, a publicly elected hospital board, I think we called that economic credentialing, is what we were talking about, because they just don't want to admit the surgeon, partly because they don't want competition. Can you explain that a little bit?
Oh yeah. So this is something that I had no idea about before I started my own practice, right? When you're in training or you get a job at a hospital, they just paved the way for you to get admitting privileges. Anyways, so when I started, I would go to a surgery centers near where I live, and I'd say, "Hey, I'd like to bring my cash-based surgery practice here." You talk to the CEO of the surgery center. He says, "Phenomenal. That's great. Just go get admitting rights at this gigantic hospital system that's down the road." So So two problems. One is I don't want it because I don't want to take call. I don't want to be part of the system. I don't want them benefiting off of me because you know what? They don't benefit the community. They're gouging people, and they're sending people to collections, and they're nonprofits. So you have a nonprofit not paying taxes, also sending people to collections and bankrupting them. And how is that right? Anyways, forgetting
Yeah,
that
I agree.
aspect of it, let's say if I did want admitting privileges, somewhere on that credentialing board is another orthopedic surgeon, all right, in the area practicing. And they'll just just because it's anti-competitive. It has nothing to do with your skill level or anything. I talked to a surgery center out in St. George's in Utah, and they do cash. And they were telling me that they can't get their Mayo-trained joint surgeon privileges at the local hospital. Why? Because there's a local orthopedic group that's blocking them. And then you listen to that. There's this podcast called Dr. Death, which is about this neurosurgeon down in Texas who actually ended up going to prison for really just maiming people. He got admitting privileges even after he was maiming people. You had another neurosurgeon in that area would talk to the CMO and be like, "You can't give this guy privileges. He's really hurting people." He's like, "Well, we don't really care. We're going to do it anyways." So that just goes to show you that it's not about you. It's an anti-competitive thing. And a lot of these, these surgery centers say, "Hey, well, if you don't have those, then, you can't work here because it's part of our bylaws, which is based on the Medicare requirement, which they actually repealed a year ago." So, I've heard stories. I mean, that's the ecosystem. It's anti-competitive. If you're not a surgeon, you probably have no idea about it. And I've also heard a story of a urologist who did get admitting privileges by being in the military. And he went to go start his own practice. And as soon as he had one complication, he was crucified. And they removed his privileges and his ability to practice. So it's the hospital's way of just sticking their fingers in all these surgical centers and just keeping control. I found a way around that, but it was not easy to do. I basically had to find a center that doesn't take Medicare or Medicaid and didn't have requirements, and it's been fine. But yeah, that's certainly out there. It's anti-competitive in my opinion.
Yeah, absolutely it is. I think hospitals they do whatever they can to protect their own monopolies, and that's what hospitals are. Most hospitals are monopolies, and they use certificate of needs, and they use economic credentialing and things like that to protect their monopoly. And honestly, if they had to compete in a free market, in a true free market, most hospitals wouldn't be around. They are some of the most inefficient businesses. They're allowed to be inefficient because of the billing system that they take advantage of. They've really created a cartel, and they're in bed with the insurance companies and big pharma, and it's just a big collusion, and hospitals love it. So, that's kind of, I echo what you're definitely saying. So do you have I don't mean to put you on the spot, but I guess I'm going to. So
Sure.
pricing. Yeah. So, MCL, an MCL repair. Let's say you had to do an MCL repair, elective surgery, pretty much. What do you know? What would that cost somebody out the door? Your fee, anesthesia, surgery, everything, imaging if they need it.
Well, most MCLs heal on their own, so I probably wouldn't be treating that operatively. And at my surgery center right now, I don't have. Oh, well, I haven't done one of those, so I don't know. I really couldn't tell you. I could tell you. I would just have to figure it out. And part of me being in the surgery center, it was built as getting my own equipment. So I'm still in the process of doing that. So it's more small tissue things right at the moment. But I could definitely give you a binding price that it would not go over. But these large centers that have been around for a while have more established pricing in that regard. So if you had an MCL and you said it wanted operated on, I would say, let me take a look at that. It probably doesn't need surgery.
That's interesting. That's interesting because there's a lot of MCLs that are operated on. So you're basically telling me that there's probably a lot of unnecessary MCL surgeries.
There's a lot of unnecessary, lots of surgeries. And that's because
Yeah.
as a surgeon, these systems they want you to operate. They want you to operate as much as you can. So they don't care if the indications are bad. And over time, that's how these guys make money. I mean, they make money by operating, and a lot of them are really good. But over time, some surgeons, their indications can get loose where they're doing surgeries that maybe aren't entirely necessary. And that's likely one of them.
Well, I appreciate you as a surgeon sharing that because I don't think a lot of people realize that. They just wash their hands of taking care of their own medical care and say, oh, well, this doctor's licensed. He's a surgeon. He works for XYZ hospital. He's got to be good. They don't realize that doctors will actually perform surgeries that aren't necessary. I write about this in my book that 80% of medical procedures are probably unnecessary. And why do a lot of people do that? Why do a lot of surgeons do unnecessary surgeries? Here's why, in my opinion. Oh, well, your insurance will cover it. And so they can do an unnecessary surgery, correct?
Yeah, I mean they're justifying their own existence, really. And look, it's not entirely the surgeon's fault. If they're not operating, they'll lose their block time and they'll essentially get fired or pushed out. So there's that aspect on it, and that's how they make money. And I've seen this before when a surgeon says, I'll give you an example. So one time I saw part of my later training, I saw a patient with a mallet finger. Right, this is the tendon comes off the end of the finger. If there's no large bony involvement, which there wasn't in this case, you can treat it with a splint. And so when the patient's in there, the doc goes, well, we can do surgery. And what she hears is, oh, I need surgery. So now that's two surgeries: a surgery to put this unnecessary pin in the finger and a surgery to take it out. You get stuff like that, or the same surgeon. There's this girl who had it sounded like she had a shoulder dislocation, which is usually a good indication for surgery in somebody that age. Exam lined up, it's like, okay, so I order an MRI. And then he's like, no, we don't need it. I'm like, okay, that's new to me, but all right. Get in the shoulder, no tear. I'm like, all right, so what are we gonna do? Oh, we'll just tighten it up. And you start getting crap like that, where it's like they're not penalized for that sort of thing. And the system, they made money for the hospital, they made money for everybody. So, they're gonna keep doing stuff like that.
Right.
An MRI
Right.
in that patient could have said, oh, we thought there was an anterior labral tear. Guess what? There's not. You don't need surgery. I don't know. Let's just do it. I mean, that's kind of where you're at right now. I mean, and you have 5-10 minutes with a patient. Yeah. I mean, look, there's certain things that need surgery, right? Someone's got a broken leg, broken hip. They've got terrible arthritis in the knee or hip, like bad trauma, carpal tunnel syndrome for a long. I mean, there's things that yes, you need surgery, go get surgery, but there's things that are kind of on the line, and maybe they don't need surgery, and you're going to someone who makes all their money off of doing surgery. So think about that, and especially if you're workers' comp. Oh my God! So workers' comp pays more than any other insurance. Why? Because they have to. Because workers' comp patients have a huge conflict of interest in the sense that they're not going to work and they get paid and that sort of thing. So pays more than any other insurance. So man, the doctor sees that, like dollar signs in their eyes. Those guys get cut on all the time.
Wow.
Probably
Wow.
unnecessarily a lot of times. You'll see a workers' comp patient that'll have like 6 shoulder scopes or something. It's unbelievable. And of course, they're
Wow.
not better, right? I mean,
Yeah. Yeah. Wow. Well, thanks for sharing that story. So, well, we do have a question from a doctor, Dr. Jared Wallen. He's actually a urologist in Florida. Let's see. Do you have a source for the 80% of surgeries being unnecessary? Can you expand on this? That seems quite high. Certainly not in my practice. All surgeries are geared towards solving a problem and providing value to a patient. Well, Dr. Wallen, I think I use the 80%, so I don't want to put any numbers into Dr. Paull, that's for sure. I will say where I got that number from was from an orthopedic surgeon. The orthopedic surgeon is Dr. Shawn Baker. He was on our podcast earlier in February, I believe. He was an orthopedic surgeon in Arizona. And he started, this was probably about 10 years ago, he started talking to people about changing their diets. And all of a sudden, when they changed their diets, they didn't need surgery anymore. He actually got blackballed from his group of surgeons and the local hospital because he wasn't doing enough surgeries, kind of like what Dr. Paull is talking about. And they filed unnecessary complaints, so to speak, and he had to fight for his license and all that kind of stuff. And when I asked him on our show, he also, if you look him up, Shawn Baker, he's also the author of the Carnivore Diet. It's a great book. Obviously, it is what it says it is. He taught his patients how to eat keto. They got better, and then he transitioned more into carnivore. He wrote a book on it. He's got a whole program on how to teach people to eat carnivore only. And what he's found is that a lot of people's orthopedic problems would heal when they went carnivore. And I asked him the numbers, and to tell you the truth, I'm a pharmacist. I'm not a doctor or an orthopedic surgeon for that, for sure. And I asked him, and I thought the number was going to be 50%. I said, Dr. Baker, how many of your surgeries could probably be prevented if they changed their diet and lifestyle? I was expecting 50%, because when we look at the regular medical system as far as chronic disease like diabetes and high blood pressure and all those other diseases that are related to lifestyle, most of those can probably be healed by 80%. But I thought, this is orthopedics. I mean, you need surgery now. And he's the one that gave me that number. So we can share that podcast with you if you're interested in listening more to it. He's the one that gave me the number of 80% of orthopedic surgeries can be prevented if people change their lifestyle. I will let Dr. Paull go on to this. Dr. Paull, how many people have knee problems, hip problems, and they just need to lose weight? Can you help me on that one?
Well, I don't know if I could give you a percentage. The American Academy of Orthopedic Surgeons, the only thing that has like really great evidence for working is losing weight. And that's kind of people assume that, oh, I lose 5 pounds, but you don't realize when you're going upstairs, that's 6 times the force of your weight through your knee. So that 5 pounds could be 30 pounds, and you lose 50 pounds, you're looking at 300 pounds through your knee.
Wow.
So there's that mechanical aspect of it. And then there's also, as we're learning more, arthritis is not just a simple wear and tear thing. There seems to be an inflammatory component, which we're learning about. And actually, fat cells themselves historically were thought of as just an energy store, which they are, but they also secrete hormones called adipokines. So there's a thought that they lead for this inflammation as well, because when someone's overweight, you not only see arthritis in the weight-bearing joints, you also see it in non-weight-bearing joints, such as the hand. So I can't say how much would be lessened by losing weight, but it would probably be a significant portion. And then there's also patients that have arthritis that isn't painful. We don't really know why that is. But there's part of people, you get an x-ray, wow, it looks like terrible arthritis. You're like, yeah, it doesn't bother me. So you leave it alone. So it's hard to say. I mean, the surgeries that I'm talking about being unnecessary are not lifestyle related. They're more, this is the situation or trauma or something like that. And like surgically, it should be treated conservatively, by any standard, and they're not. These are things like you should not be doing an MRI, a shoulder scope on like a 22-year-old shoulder without an MRI. So I don't know what percentage that is. Most docs are very good and don't do that kind of stuff, but the ones that do, they're out there.
Yeah, for sure. Well, so we're about winding up our show today, Dr. Paull. And speaking of inflammation and arthritis, we will have Dr. Diana Garnita on next week on our midweek podcast. And she's a rheumatologist, and she's a cash-only rheumatologist, doing kind of what you do, got out of the system so she could take care of her patients better. So she'll be talking about a lot of the inflammatory components and not just drug treatments, but we're going to talk about a lot of the lifestyle treatments for arthritis and those types of inflammatory or rheumatological diseases. So stay tuned for that next Thursday, 8 to 9 a.m. Pacific Standard Time. So Dr. Paull, what do you have a passion for? What drives you?
My real driver right now is I want to disrupt. I want to disrupt really bad. This medical system you can't fix it. You said that before, and I totally agree with you. It's like a structure fire in a house. You just need to build a new house. And part of that is people doing what I'm doing. or the DPC docs. And this isn't going to come from top level, bureaucratic type stuff. It's going to come from bottom level people like me, just deciding out to participate. But yeah, my goal is to disrupt. I want these insurance companies and hospital systems to realize that, you're raising your premiums every year and the product you provide is not good. And I want people to start leaving those companies, en masse, and them say, hey, wait a second, maybe we should actually create a better product, instead of just, ripping companies off. Companies paying what, $20,000 per employee per year. You're not getting a raise next year. You know why? Because the raise money you got is going towards your insurance premiums. People aren't super privy to that, but I think it's totally messed up, and they need to be disrupted, and I think they will be. It just will take time.
I love it. I love it. Disruptors. Sometimes disruptors aren't very popular, but I'll tell you that's what really drives change in all kinds of systems. So I appreciate you being on today, Dr. Paull. I appreciate all the expertise you provided to our listeners and viewers. You are definitely helping. Cast our goal, which is to educate and empower consumers that they're in charge of their own health. So we're streaming your website there as we speak, and I so appreciate you being on. As always, you've been listening to Health Solutions with Shawn and Janet Needham. Tune in Monday, 1 to 2 p.m. We will have Sam Tran. He used to work for Big Pharma. He believes Big Pharma is not out for our best health and wellness needs and wants. So he left Big Pharma, and he's going to talk about lifestyle and changes, how people can create their own health by lifestyle changes. So tune into that Monday, 1 to 2 p.m. Have a wonderful Thanksgiving tomorrow, wonderful long holiday. I appreciate everybody listening and viewing. Thank you so much.